Today, we will present on the development and testing of the Care Path for Kids model and tool, and discuss how families and pediatric care teams can integrate the model into the overall shared plan of care. So I'm Christina Bethel, and I serve as a professor in the Bloomberg School of Public Health in the Department of Population, Family, and Reproductive Health, where I also direct the Child and Adolescent Health Measurement Initiative, and had the pleasure of serving as the principal investigator with many partners in this study that led to the design and testing of the Care Path for Kids. I'll be moderating today's discussion, and we are recording this webinar, and it'll be available on the Lucille Packard Foundation for Children's Health website in the coming weeks. So joining me today is Jonathan Cotter, who is a father of a child with special healthcare needs and advocate. Melissa Vickers, who is a project director with Family Voices, who has worked with us extensively in this along with other families. And Dr. David Bergman, professor in Stanford University School of Medicine, specializing in the care of children with complex medical needs. And today we will briefly cover the Care Path for Kids. I'll be giving a quick overview. We want to talk about the family context and perspective and need, as well as the family role during the development of this work, and talk about the basis for improving care, engagement in shared care plans, and how that might look in clinical practice. And finally, just a little bit on dissemination and next steps, and then we want to engage you in a question and answer period. So this is really probably the most important slide. We will look forward to a lively discussion and want to make sure that all of you take a moment to know where your question and answer button is on this Zoom. If you click more, you will see it as one of the options. So it's not the chat, it's actually the Q&A function, where we'd like you to put questions that you'd like us to address openly during the webinar when we get to the question and answer, which we're leaving a lot of time for. But we also really want you to use the chat function throughout to share perspectives, responses, share about your work, talk to each other in ways that we hope you'll go ahead and do. But before we get started with the overview, to help us best meet your needs, we want to know a little bit more about who you are. So we're going to have a poll. So go ahead and put the poll up. Thank you. And just to answer here who you are. Your primary interest in learning about the Care Path for Kids model and tools today is as. So to our help here on the webinar, when you feel that there's a good number proportion, go ahead and show it, but I'll let you decide how many, whether we have enough people. I saw someone say there's overlapping reasons to be here, of course, and so thank you for forcing yourself to pick. Okay, great. So just if everyone can glance at this to see who's here today. So a lot of care coordination professionals and also care team professionals, some family members, research and advocates, and then others. So I'm curious who other are. You can go ahead and share in the chat who you are, because we really would like to know. Okay, so I'm going to go ahead and get started with the overview as we proceed. Next slide. Okay, so to begin, let me give you a quick overview of the Care Path for Kids. First, the Care Path is an acronym that calls out a way of conducting partnerships with families, beginning with connecting, with presence and connecting and creating safety and trust. And then to go on to assessing immediate needs, as well as larger and long-term needs, but assessing and responding to immediate needs, which is always critical. And then identifying with families, engaging them to reflect on the well-being of their whole family and child, including creating a map of all supports and care they use and need right now, and to then identify goals and priorities for their child's health and healthcare, to be sure to articulate this in detail in words, and then translate these priorities into specific actions that can be taken by the care provider and care team and families or others to And finally, this last part is to honor, to use the Care Path for Kids plan that emerges from this body, the tools, to reflect and update it on a continuous basis, to update goals and priorities that can help guide the rest of the care planning and care process. So the Care Path for Kids specifically includes 3 interlocking tools. The first engages families in completing something called the Family Foundations of Care Planner. The second is using that information in a shared encounter with a care coordinator or other person in the practice or care team to create a Family Foundations of Care plan and dashboard that is then used in the context of clinical care to help anchor that care according to the family's goals and priorities and what they've shared, and to continuously update that. So next slide. I want to emphasize that we place this work in the broader work of shared care planning, and we want to emphasize that the Care Path for Kids is designed in the first step in the broader shared care planning process. And we envision that you would use the Care Path for Kids with families so they can reflect on their strengths, priorities, goals, their social and environmental context to shape the Family Foundations of Care plan. And then using this to then expand out to the larger key elements of a shared care plan, like all the medical history, treatment plan, and ER plan. So it gets integrated and it's a foundation for that. And then, of course, moving on to what the other special elements of a care plan may need to be regarding supports like school and community-based services and the larger plan of care overall. And then finally, we hope that the information that you would gain from the Care Path for Kids would be a learning to bring into all the discussions about how systems need to organize themselves for care and supports that really take into account what you're hearing from families that can promote the whole health of the child and family. And finally, before we move on, we do have an implementation manual, and the key steps are to really focus on engaging families in an outreach and education engagement process that shifts the culture to make sure that we begin care with their input, team and prep work to plan and get ready. We have conducting those relational meetings with families. How does that work? We have outlined resources for that. And then conducting the provider and family visit, and then proceeding in ongoing care coordination. So we have a website, a humble website, but a website where you can access all the tools and resources we have and to share more about how we can help you use these. And before I move on to Jonathan to tell you more, I would like to take this moment before we do move on to acknowledge the Lucille Packard Foundation for Children's Health for their support for this work, and also specifically to Dr. Jeannie McAllister for her partnership in this work and her leadership in developing the shared care plan model upon which we based all of our work. Finally, our 32 family partners, 26 clinical partners, and an amazing national advisory group of 17 people, including some of whom I hope are on the call with us today. So with that, I'm going to turn this over to Jonathan Cotter, who will share more with you about the family and advocacy position on this work.
Fantastic. Thank you very much for letting me share today. My name is Jonathan Cotter. I live in Scottsdale, Arizona with my wife of 28 years, Holly, and our older son, Ethan, who is a bassist in a death metal band. After a long career in corporate marketing, I've decided to do a significant pivot in my career to really focus on my heart. You may have, so I'm finishing up my MPH degree at Johns Hopkins Bloomberg School of Public Health next month, and we'll be focusing now all of my energies on supporting children with complex medical conditions and their families. You may have noticed in my bio that my wife and I co-founded a pediatric palliative care and hospice home in Phoenix called Ryan House. Ryan House has been open now for over 11 years. We've served thousands of families. Over 450 children have died at Ryan House, including my son, Ryan, who died there in December of 2018. Next slide, please. So I want to introduce you to that young man. Ryan and his older brother, Ethan, are in that left picture. That photo was taken 3 weeks before we were given a life-limiting diagnosis of spinal muscular atrophy. At that time, there was no cure, there were no treatments, just take him home, love him, and he's not going to survive till his second birthday. So our world was shattered. The photo on the right is Ryan a few months before he died at 17 years old. Ryan was incredibly bright and mature. He was also very physically challenged. He needed an adult caregiver for all of his daily living needs. That included eating, drinking, bathing, toileting. He needed to be changed positions when he slept each night. There were physical therapy appointments, chest vests and BiPAP machines to help his respiratory breathing, hip surgeries, spinal rod surgeries. We spent many a night in the ER and in the hospital rooms with pneumonias and other conditions. The hospital became our second home. Ryan lived a phenomenal life, but it was way, way, way too short. Next slide, please. One of the tools that's helping families and providers connect is a care map. And the Care Path for Kids model includes tools that support creating these visual tools. So I'd like to share Ryan's care map with you to help understand and visualize the overwhelming. It captures all of the touch points that are incremental to a, let's call it a normal child's life, whatever normal means. I think we all recognize that there is no such thing as a normal. But these are all the providers and services that a child like Ryan is involved with in his daily care. When others see mountains to navigate, I also see mountains of paperwork to coordinate. It's overwhelming, families are stressed, and they have many unmet needs. Next slide, please. So I wanted to talk about this in terms of when families are trying to navigate the journey. They're looking for help. They're looking for support. Who can help them? Is it grandparents? Is it aunts, uncles, neighbors? There's lots of people that want to help a family, but the daily living requirements and all of the equipment requirements become very uncomfortable for most people to handle. There is certainly home health and attendant care, but those, because of the low rates that those positions often get, that turnover happens quite regularly, and it can be quite a challenge for a family with a special healthcare need to handle. What needs to happen is that there's more than medical involved in a daily life of these families, and you really need to step back and have a holistic view to really grasp what's going on. Let's go to the next slide. So my family journey is unique, but it's not unusual. So what I'd like to do is widen the lens and really present 3 family scenarios, each focused and centered on a child with a special healthcare need, but really look at it from a holistic view. No day is like the last one, and who knows what the next day is going to be like. But let's pause and listen to today. So let's first focus on invisible, a young girl with diabetes, just trying to learn to manage her blood sugar levels. That may not be as obvious for her friends at school, for parents, for neighbors, or teachers that might not see a child with a special healthcare need. But let's look inside the home and really understand what else is going on. Here she's got an older sister that's having some behavioral issues at school. That's creating a lot of parent-teacher conferences. The family is having the parents are having some marital rifts and are now talking about getting divorced. So from an outward perspective, they put on a happy face and few people might know what's going on, but inside the home, their stress level is very, very high. Let's shift over and talk about isolated. 7th grade is a tough transition year for any kid. There's lots of sports, lots of social anxieties in the 7th grade year, but now let's talk about a young boy with cerebral palsy. He uses braces to walk. Maybe he has eating and speech difficulties and a hard time making friends at school. From a parent perspective, the family life seems to be pretty good shape. Both parents are working, they've got good insurance. Grandparents are out of state, but they fly in every once in a while to help out for a few days. The challenge that a family is having here is afternoon attendant care. They're really struggling because of the Medicaid rates for those attendant positions are so low that they're really having continuity of care issues, and they're struggling to try and keep somebody in place. So the conversations that are happening in this house now are about maybe one of the parents needs to stop working and really become now a part-time or stop working completely just to be able to manage all the care that's going on. Let's shift now to impossible. Twins, 2 boys with Duchenne's muscular dystrophy. I personally know 3 families in this type of family context. Twins are not twice. Each child is an individual and a unique child. That also means that they have their own personalities and their own pathways. One child might get the flu and the following child might get it the next week. They might both develop into pneumonia and wind up at the ER at the same time or staggered. Both children may end up in powered wheelchairs like my son. And when you have two wheelchairs, that's a pretty big van to kind of maintain that lifestyle. Let's also add in that this family lives in a rural area. So they're over 100 miles away from the children's hospital where all the specialists really tend to focus, and that's where that care is. So not only are they having to drive and commute quite a bit for the care that they need, but they also don't have that much support in their local community. So impossible, yet families are doing this, and they need their help and support. Invisible, isolated, impossible. Next slide, please.
Jonathan, thank you so much for setting the context of what families are experiencing. And we're looking forward to hearing more from you about the care path for kids and how that might be able to support that. But we're going to go on now to Melissa Vickers, who will share from Family Voices as our key partners in the development. Thank you, Melissa.
Next slide, please. So how do we go from the very personal, real life stories of families determined to do their best for children with complex medical needs to a tool designed to help them accomplish that? I'd like to take some time to give a little historical perspective on the development of the Care Path tool, specifically the role of Family Voices in helping to define and adapt the tool to make it work with families with these children with complex needs. The Family Voices mantra has long been keeping the family at the center of children's health care. We work to train families, including youth, to become leaders to help other families navigate a complex healthcare system that's often overwhelming. Our goal is to help families build strong relationships where they are equal partners with healthcare providers in the healthcare of their children. Each partner brings strengths to the table, and each must rely on the other for comprehensive, culturally competent care. Family Voices has a long history of working with CAMI. It's a natural fit as CAMI looks to build those same relationships and partnerships through its tools like the Care Path and others. CAMI seeks input from those their tools are being designed to help, whether family or healthcare providers, and they take that input and they put it to good use. Next slide. First, though, a disclaimer. I do not have children with special healthcare needs, and none of my 5 grandchildren have them as well. So my role all along has been as a facilitator to bring family leaders together to talk about their needs and how a tool might help, but also as a learner. I have learned so much from these families about their day-to-day lives, including that my assumptions about these families really were pretty shallow and lacking real understanding. The family leaders I worked with ranged in age from relatively new moms to grandmas, and quite diverse in terms of race, geography, and range of health issues and the medical complexity of their children. It was an amazing group to be a part of. Next slide. The CAMI team created the starting point for this new tool, and family leaders provided input on how well this new tool might meet their needs. They wanted a tool that would include not only the medical appointments, treatments, and medications their child was receiving, but would also look at the bigger picture of the child and family as a whole. We had group calls as well as 3 individual cognitive interview calls to explore in depth how a family might use the tool. Some were eager to start using the tool and even share it with the other agencies they were working with. They suggested ways to organize the big blocks of material and suggested ways to word questions to be more family friendly, especially some of the more potentially sensitive questions. They envisioned the tool, using the tool as an online, on-the-go tool that they could take with them and enter information on the fly. They wanted to be able to share the tool both with other family members or caregivers who might have useful input, as well as sharing across the many specialists and others associated with the care of their children. Some of their ideas were beyond the current funding availability, but they were so excited about the potential for the tool that they felt free to dream big. These family leaders, typical of many parents of children with complex medical needs, know that sometimes it's the family who drives the care coordination. And they saw this new tool as something they could use, regardless of whether or how soon their child's healthcare team were using it. Next slide. They acknowledged that for such a tool to really encompass everything relevant to their child and family's world, it would likely be a long tool. The value they get from the tool had to outweigh the time involved in using it. Otherwise, it just becomes busy work and an exercise in wishful thinking. Next slide. Families wanted these things to be represented in the tool and how it's used. It has to be easy to fill out, understanding that some sections might take more time and effort to think through than others. It has to be easy to make the inevitable changes, big and small, that happen with children and families. It has to be easy to share with all relevant parties, whether healthcare team or families who might be helping out. It has to be easy to identify the pressing needs of the day. And most importantly, it has to be easy to identify with. The tool has to feel like it was made for them. Next slide. So in short, families wanted a tool that would be more than just a laundry list of medical procedures and appointments. The health care of their children had to fit in with the greater world of their family life. Because even the best medical expertise is useless if a family can't make it doable. Helping the healthcare team see the bigger picture sets up an attitudinal shift designed for greater success for everybody. As one family participant put it, this tool is going to help you help your team understand your situation and your needs. I think we see ourselves as constantly going while trying to get other people on board on my bus. The way I see it, this is a tool to get people on this bus and understand where I'm going and how they are going to support me to keep this bus going. It's about them understanding our situation so that they can help us. So the ideas and suggestions that the families made, many of which were incorporated in the care path, combined with the ideas and the implementation of those building it, have created a tool that families are excited to be able to use. It really is all about getting people on that bus and keeping that bus going. Thank you.
Thank you so much, Melissa. And I'm going to turn it over to Dr. Bergman now to share a little bit more about his perspective and experience with the Care Path for Kids. Go ahead,
Thanks,
David.
Chris. Thanks, Christy. What I want to talk about today is the perspective of the provider in using the Care Path for Kids tool. One of the implementation sites for the Care Path for Kids was a complex primary care clinic at Stanford Children's Health, where I am an attending physician. As such, I've been very much in the weeds with the implementation of the CPK in a busy clinic, and it's this experience that I'd like to share with you. I would guess for most of you who came to this webinar, you're already spending a great deal of time involved with the care coordination of complex patients. Furthermore, I would guess your plate is full, assessing patient and family risk, social determinants of health, completing shared plans of care, and collaborating with families to develop shared goals of care. If you're like me, the idea that you can wedge one more activity in a busy day seems close to impossible. If you're going to take on another tool, you want to make sure that it will make a difference and that it will rock your world. Next slide, please. There are 4 major reasons I feel the Care Path for Kids will make a difference for your practice. First, it works to meet the needs of children's families and providers. Second, our research has shown that it can improve the quality of the encounter for both the family and the provider. Third, we have found that you can implement the Care Path for Kids without disrupting your practice. And fourth, using the Care Path for Kids enhances your connection with families and provides an important antidote to burnout. And I also add that it's good for your soul. So let's look at these points in more detail. The next slide, please. Okay, for parents, the Care Path for Kids provides a more holistic view of the child. To return to a quote from one of our family participants, providers do not know what they don't know about us. We have to give them the whole picture. The Care Path for Kids facilitates the development of this more holistic view of the child that reflects the family, the environment, and the complex ecosystem of different individuals and agencies that contribute to the health of the child. The Care Path for Kids also enables the family and provider to move beyond the problem list as the foundation for care management through the development of a shared plan of care and child and family goals. The shared plan of care then can be utilized across the multiple agencies that are involved in the child's care. For the provider, the Care Path for Kids allows you to develop a more comprehensive understanding of the child and the family. What we as providers found out in the implementation study is that this frequently led to the elucidation of new knowledge about the child and family. The care path for kids also increases the efficiency of the visit because much of the work of the family is accomplished asynchronously before the visit. The process is respectful of your busy schedule and time limitations. Lastly, many managed care plans are requiring providers to develop a shared plan of care. What the Care Path for Kids does is an opportunity to do it right. And the next slide, please. So as you can see from the charts above, our research has shown that the use of the Care Path for Kids improved the quality of the visit for parents, with 82% of parents feeling the Family Foundation of Care Planner increased the value of their child's care. 91% of parents felt the Care Path for Kids helped them to learn about more important topics for discussion. And lastly, 95% of parents recommended the Care Path for Kids to other parents. The next slide, please. So our implementation study also demonstrated the Care Path for Kids improved the quality of the visit for providers. In particular, you can see from the top bar chart, providers felt that the Care Path for Kids filled the need for creating a shared plan of care. And as shown in the bottom bar chart, enhanced provider work satisfaction. Next slide, please. So one of the most important findings from the implementation of the Care Path for Kids was that the use of these tools did not blow up the workflow at our clinics. Needless to say, this was key for our successful implementation. So why is the Care Path for Kids different in this respect? It's flexible, allowing you to use one or more modules depending on your time constraints and the needs of the family. 2, much of the work is done before the visit, allowing both you and the family to enter the visit activated and attuned to issues that need to be addressed. 3, the use of the Care Path for Kids can usually be done without the involvement of additional clinic staff. But clearly some families do need assistance in completing the forms. But at Stanford, we found that we could use parents to help other parents with this task. Next slide, please. So this is the part that's personal for me. With the advent of the COVID-19 pandemic, providers everywhere have been dealing with loss. Over 40,000 children have lost a parent to COVID-19. We've been dealing with the frustration on families who have not been able to receive the inpatient education and rehabilitative services they need. And for providers, there's been a lack of time to accomplish meaningful work, with over 50% of our time being consumed in care coordination and documentation. All of this has led to provider burnout and moral injury. And I would argue that these stressful times and dysfunctional systems have diminished our ability to form caring connections with our families. And this is what makes us healers. And this is the reason most of you work in healthcare. Now, I see myself as a sensitive and caring pediatrician who's been taking care of kids with special healthcare needs for over 4 decades. Even with my extensive experience, I found that using the Care Path for Kids created connections for me and conversations with families that I found new and that for me greatly contributed to the healing process. So if you have one takeaway from my presentation, it's this: the Care Path for Kids, it's good for your soul. So I'll now pass the baton to Christy for our second poll.
Okay, great. So we're going to do a second poll first and then open it up for questions and dialogue. So you can start the poll. And just based on what you've learned already in this quick half hour, does the Care Path for Kids appear to be valuable to your efforts to support children and youth with special healthcare needs? I just want to get a little bit of feedback here. So go ahead and to our poll manager, go ahead and show it when you feel we've had adequate input. Okay, great. So we mostly have absolutely or very likely and wanting to learn more. So I'd love to hear from the not really, we already do something similar. That would be great to learn about. And perhaps there's some way we can learn about that and help our own work and do better even for families. So we're going to go ahead now and close the poll and start our question and answer. I just do want to make sure, because somebody did ask, that the resources are available on our website, carepathforkids.org, so you can find what we have available right now. And this is going to be an ongoing partnership with the field to learn how to continuously develop and evolve this work in collaboration. Okay, so in terms of questions, I'm going to go ahead and pose a question to David and about the opportunities for this to be integrated into the electronic health record, because that's a common question that we're getting. And how does this work in terms of that kind of integration?
Thanks, Christy. I think for many of us who've tried to implement new tools, one of the big bugaboos is, well, it doesn't integrate in a seamless way with my electronic health record. And I'll find myself having to go outside the record and complete the form and enter it again. The reality is that we do a lot of this now anyways. So for pediatricians, for example, developmental screening is also a task that's usually accomplished outside of the context of the electronic health record, but often it's scanned and then ported back into the record. Currently, this is a paper and pencil tool primarily. Our hope is with further development that will make it interactive and web-based. But I do think it will kind of fall within the panoply of tools we'll see in the future that are used outside the electronic health record, but can be easily scanned and incorporated into the record.
Great, thank you, David. So there's a question about how long it takes. And so in our work with families, it was anywhere from 25 minutes to a half hour for them to complete. And it's important to know that families can fill out part of it and not all of it, and come along through an ongoing process. So sharing about what parts make sense to them. So it will vary, but overall it's about 25 minutes to a half hour is the timing that we had. There was also a question about whether it's available in Spanish. And so we are in the process of translating the tool into Spanish, but we would really like to partner with somebody in this because it's very important to get that right on the ground. We did try this in a clinic here at Bayview at Johns Hopkins that had a lot of Spanish speaking families. And so we have a lot more to share about how that worked. If you particularly want that, please email me, and we can share more and quickly get the Spanish versions up and available for you. The next question was really about cultural needs and strengths. And I'm going to ask Melissa maybe to comment on her experience working with a variety of families about how this worked across families with different kinds of cultural or strengths, cultural identities, cultural norms, and different levels of strengths and needs.
Okay, thanks, Christy. And that's a really important issue. This has to work for more than just, one standard iteration of a family. And we have so many families, so many cultures, so many traditions and things that need to be respected on here. And I think part of what makes this work is that the tool goes out beyond just the medical stuff and gives the families an opportunity to share more about what their life is really like and what kinds of things that they've got to be able to work into what they're doing with their child that has the special needs. The group that I worked with was pretty diverse, and I don't know that that really ever came up with as an issue because they felt like the tool was allowing them to express their differences and help let the care team know, look, this is who we are, this is how we function. Even the things like there's an opportunity to create vision statements and goals and things like that. Those are perfect opportunities to weave those cultural aspects in. So some of the rest of you may have a comment.
I mean, that's great, Melissa. And in one of the focus groups we did at the Family Voices National Meeting was one of the ones we did. Somebody really noted that when I have really basic issues with food insecurity or housing or things like that, that has to come first in terms of helping my family. And that is exactly what the Care Path for Kids is attempting to do in that Care Path model, where you first assess immediate needs and respond. So in terms of disparities and families who have more social determinants, it immediately brings that to the fore so that you don't miss that step and start going into all of these things that need to be done when there's more basic needs at hand. And that was an important piece as well. So I'm getting another question about making sure that both the provider and the family are on the same bus. So we talked about the bus. And, you know, we've developed this in a collaborative way between families and providers. And you were right, the person asking this question, that we want to have providers interested in sponsoring this and inviting families to participate, and then having it be both ways. But you're also right that it is something that families can use on their own and be able to bring that leadership to the practice if they want to. Ideally, and we have this model for something called the Well Visit Planner, which is another tool that we've developed with families, where providers have the opportunity to get an online account where they can actually have the data filled out electronically by the family, have that shared plan, and have that put into a dashboard that can be accessed and then put into the record and used, so that they really have a seamless integrated whole. And so we hope we can build on that work that we've done in the past to make it really seamless, so that you have a provider who's sending a link to a family, a QR code, and getting the data back seamlessly. But David, do you want to say anything more about that, about how to make sure that both providers and families are engaged in this together, and that we don't just have families coming in trying to convince providers to use this, and maybe the other way around?
Yeah, I mean, I think that's one of the beauties of the CPK, at least the Care Path for Kids in my experience, is it does get you on the same page. Too frequently, providers go in with agenda and families go in with an agenda. And then there's an unspoken agenda on the part of both participants, which makes it really confusing. The beauty of the Care Path for Kids is that you work collaboratively to develop what are the goals of care and the shared plan of care. So it's one of the neat things about it, it kind of almost mandates that you're on the same page. If you go through the process, you'll end up hopefully in the same place with the same care plan for the child.
Yeah, okay, great. Jonathan, do you want to say anything about that as a family member?
Yeah, I just going through the research and just learning more about the development of this program, I was really connected to verbatims that said things like, from a family perspective, this really helped me think about things that I hadn't really thought of before. And I think that that's really a powerful element of what this whole approach is about, is that the questions and the tools really help bring out stuff that the family may be hesitant to want to raise or hadn't even really thought to want to raise. So it really just broadens the conversation to a whole nother level and connects the provider and the families. That's, I think, one of the powerful things about it.
Okay, I think related to this is another question that just came in, which is really about recognizing the cultural shift and attitude shift that may be necessary to create a container in which the Care Path for Kids would be desired to be used and used effectively. And here, I'm curious to hear from either Melissa, Jonathan, or David, and maybe start with David a little bit about what are the attitudes and things you kind of need to believe in to even begin to think this would be important as a provider, and how do we help make those attitude shifts in our health systems at a clinical level?
Well, it's a really important point. I mean, and it really starts with the role of families. And many of us pediatricians really see us as very respectful of family. And in many of our organizations, we have family advisory councils, which kind of give their imprimatur to policies that are coming through the pipeline. But rarely have we made that kind of cultural shift where we consider families as partners and families who bring a unique body of knowledge to planning their care and are really there to co-create and co-design the care for their child. In my experience, this is a cultural shift, and it does demand talking through it and making sure people understand it, and that families are treated as true equals and partners in care.
Great. Jonathan or Melissa, did you want to say anything more about that? About sort of what are the beliefs and attitudes that you see may need to be shifted, and how can we do that?
I really like, or go ahead, Melissa, if you want to.
Oh, go ahead, you started.
Well, I was thinking about the holistic view, and I was thinking about care maps, and I was thinking about the importance of especially the medical providers really shifting mind and opening up minds to the holistic view of all the things that are going on with these families, and vice versa. I mean, it's all the way that the families or the other providers, the DME suppliers, the durable medical equipment suppliers, and the therapists and the education with the, I saw in the chat, somebody had commented about this would be a great fit with an IEP program. Exactly. I mean, in the life of a family and a child, there's so much going on, and this just really helps support all of that.
Right, Melissa?
I might add, I think in the past, the traditional view of the relationship between the family and the healthcare provider is that the healthcare, the doctor, whatever, had the final word. They had the only word. And so that left families with the option of either doing everything that the doc said or ignoring everything the doc said, depending on whether or not it fit with what they were doing. And I think what this tool does for families is it really does open up the realm of things that, like one of you said before, that it is important for the healthcare team to know what else is going on in my family other than this visit right here today with this medication and this treatment and this whatever. So it helps families shift around and realize that they can drive the conversation, and that's such a switch. Certainly when I was growing up, that wasn't the case, and gradually hopefully it's moving that way, and I think Family Voices has done a great service in helping to move it that way too.
Yeah. I'm going to go ahead and answer a few of the questions, but just to round out some of the input, one of the comments that we had from a provider who's an incredibly family-centered provider, I think famous for it really, was, I really never asked what their vision for their child was. And I never really found out, what does the child want to be when they grow up? And the children have visions and dreams for their lives, and so do families. And the feedback was, when I found out that the child wanted to be, a veterinarian or to work with animals, it completely changed, where the care was like, how can all of this care help you be that? Or that I want to get on a plane with my child so that they can go see their grandparents who are not well. How can we make that happen? So the care actually ends up with a North Star, and that was very powerful and just something that wasn't really thought about. So it will prompt you in those things that can help start to naturally build down barriers by bringing positive experiences to the care process for both the provider and the family. So I'm going to answer a couple quick questions, and then I want to talk about an important one that came up. First of all, who is responsible for this and who holds it? Obviously, it's shared, but ultimately the family is the one that gets to say, this represents what I want. And to be able to complete it regularly and to continuously update it is really held by the family, but there has to be somebody that they see is working with them to continuously update the dashboard, and that changes the answers to those questions about their whole health and their care map and the pieces there. So it really is truly shared, but the family needs to have a sense of ownership and also an agency, and to be really truly welcome to update this at any time and not have to wait even for the provider to invite them, although hopefully that would happen. And that gets to what Melissa's saying of, holding back and not necessarily being assertive because you were never asked about this before. So that's a quick question. How often to use this? That's really similar. I mean, it's really as needed, but mapping it out, what would be the trigger points? So any major changes in a child's life or opportunities. So we want to make sure we map that out for families. Here are the times when you might want to fill this out. I'm going to ask Jonathan if you want to comment on this more about how often, because some people have a change that they might make as they learn. Like, I filled this out one time and these are the goals, but as I thought about it more, this came up. So I want to ask you about that, but somebody did say about what about checkups? And I want to just say that this was a overall 3-year project. We created something called the RISE tool, which is a lot like the Well Visit Planner, but for routine visits for children with complex medical conditions. It's an online tool that can prepare for visits. And also doing well, making sure children with special health needs and complex care have well visits. So this definitely can accompany that, but there's also some other tools that are out there to help make sure that there's something specific for kids with special needs for well child care, and they go together. But Jonathan, maybe you can talk a little bit more about how often would a family member need to use something like this, or could, and how that wraps for you. Maybe David, you could comment too.
Yeah, I think the reality is that life is day by day and it changes radically. And so especially when I think at the early stages when a child is newly diagnosed or a family is just starting to come to grips with kind of their new pathway, their focus is really not as much about, they're worried, they're scared, they're stressed. And so I think a lot of the attention is really about just meeting some unmet needs, getting them resourced and getting them connected, which again, the tool set will help provide more specific things that are very short term in nature. I think as the family then kind of gets comfortable with, okay, we're now at a pace, and that pace can change because all of a sudden a pneumonia happens or something winds up in the hospital. But I can tell you that my son lived for 17 years. And at the beginning, we didn't think he was going to live to 2, that we wouldn't be celebrating his 2nd birthday. So as he got later in his life, we started to be able to think about things like, Christina, you mentioned, in terms of visions and goals and really fun things about, hey, maybe there is a high school in his future. Maybe there is a college in his future. And that's really where I think a family can get to enjoying some of those goal thinkings. In the beginning, certainly for us, it was very much short term. How are we going to do this? How are we going to support this? How are we going to have care needs in our home today? How are we going to pay for all of this stuff? And I think there's no magic month that you should update this. It really is going to be about the family path and the stages that they'll drive the need for that.
Great. David, did you want to say anything about that?
Actually, I think Jonathan covered
Okay.
it eloquently.
Okay.
I think at Stanford, what we try to do, at least as a minimum, to look at it every 6 months. But obviously, with rapidly changing situations for these families, it may need to be adjusted more frequently.
Yeah, and the H part of CarePath is the honor part. And that really would just build in a recognition that you have this dashboard with this Family Foundations of Care plan that is a foundation for other care. And you want to just continuously invite families to make sure it still reflects what they want. And so that can become just a quick honoring at the encounters that you have. So somebody said every 6 months they do theirs. And yes, this does encourage asking the child themselves what their own personal vision is for their lives. And so somebody asked about that. And I'm going to turn now to an important question, which is all about how do we create incentives and systems that support us to do this kind of innovative work. And we've gone a long way because now shared care planning is part of some of the requirements for caring with kids with special needs, family engagement on top of that. And there are performance measures and there are payment incentives that are out there that need to start aligning more specifically with implementing these kinds of activities and recognizing them as important things to include potentially in performance measurement or as a way to improve the performance measures and also value-based payment. And so David, this is a specific question to you about how do we get buy-in and support at that systems level and policy level? What are some reflections you have about that? And also Melissa and Jonathan, if you have some comments about that as a family person.
Sure. I mean, I think we could talk hours about this, but I think if you look at most organizations, it's interesting that they're concerned very much about customer satisfaction, patient relationships. They want their patients and families to keep coming back. And in many ways, the CarePath for Kids provides a mechanism for creating caring connections that really bond families to the institution. And the institution can see some real advantage to that. Similarly, most institutions and systems are paying attention to burnout. We're seeing prevalence rates of up to 40% in providers of children and adults with a medical complexity. I think, as I've tried to convey, is that I think an important antidote to this is to allow us to shift or reframe or repurpose our time so that we're doing more meaningful work. And that meaningful work is really comprised of these caring connections. The third piece, and I don't know if you want to talk about this further, obviously is incentives. How do you pay for this work? And I think there's a lot of experimentation going out there with alternative payment models that look for per member per month payment for care coordination services. There's also capitated plans which would incorporate these services under the cap fee, and that these payment mechanisms are tiered according to the level of complexity or the type of medical home. But a lot of that's still in flux. And for many of us, we still live in a world of fee for service, and getting these efforts paid for is challenging. I don't know, Christy, if you want to add to that at all.
Yeah, just first to check on whether Melissa or Jonathan would have anything to say.
I don't. I just, other than to say that, I've been doing my MPH for this past year also, and I can definitely say that I am more excited about the next few years and how this will all sort itself out and be figured out than I was 20 years ago when I started this path. Because I think that there's a lot of everybody, there's a lot of groups and organizations and payment models and everything that is really very much changing. And it's much more exciting these last couple of years than I think if you were to go back 15 years ago. The world is changing quite rapidly. So I'm confident that we will solve this together.
Yeah, definitely. I mean, we're doing a body of work overall on looking at policy and performance measurement and how the engagement process, both in the shared care plan, care path for kids, as well as some of the other work in engaging families, can be directly recognized as qualifying for the kinds of things you're supposed to be doing under these alternative payment models, and also start to get value-based purchasing to recognize the importance of these approaches and again support them. So I would love to actually, maybe that could be a really in-depth follow-up webinar to talk mostly about that. I did want to answer a couple quick questions. Somebody talked about where's the RISE tool. That tool is mapped out and created but did not get built. But however, we do have something called the Well Visit Planner, which includes information and relevant for children with special healthcare needs for supporting planning around well visits that really make sure that the provider knows about that the child has a special healthcare needs and gives an opportunity for families to really go in depth on that aspect of care that is often ignored for children with special healthcare needs. And we can share more. This is all kind of what we're hoping can be developed. But somebody asked about palliative care and how this might be supportive or what else is needed to, because this isn't necessarily the template for creating the disaster plan or the ER plan or the palliative care plan, but it could definitely support that. And so Jonathan, I was wondering, with all your leadership and work in this, if you could comment on how this might fit with that time in the process of a child's life.
I echo what you just said. I think that the Care Path for Kids model and approach really is at the very, if you're thinking about what's the first set of tools to use, I would suggest that the Care Path for Kids model and approach is probably a very good first pass, because the questions and the issues around understanding the family needs, that's a tool that will help you really start to think through those things. And then it feeds into a more robust and a further shared plan of care, palliative care, emergency medical plans, and those kinds of things. So there is a boundary and an overlap, but it really starts with, as you presented at the very beginning of that model, it really is a beginning of flourishing into a whole bunch of other things.
Okay, great. So David, I have another question for you, which is really, how does a provider decide whether this kind of tool would be relevant for a family? Like, who needs a care plan? Does everyone need a care plan? Some people say children without special needs need care plans for their wellness and development. And so could you comment on that? And then also the specific case of children who are transitioning to adulthood and how this might be useful for that as well.
I'm glad you saved the easy questions for me, Christy. It's good. I think, first of all, just remind me once again, what was the first question?
The first question is, how does a provider decide who to share this with, who to engage, like who needs a care plan? And the second one was how this really could be used or useful for children who are transitioning to adulthood.
Well, it's easy to make the argument that every child deserves a care plan because every family has goals for that child and things that they want to see achieved. I think practically we've tended to jump in with kids with medical complexity, partly because just of the intensity of the problems and the complexity of the problems are really call for a tool that will help sort this out and really help families discern where they want to go. I should add, though, that I think this is very applicable for behavioral health, too. In fact, many of our kids have behavioral health problems, and a lot of times the care coordination issues are just as daunting for this group of families. And I feel the Care Path for Kids could work easily well with children with severe emotional disorders as it does for kids with medical complexity. The transitioning to adulthood is, I think part of what we do on at least on the pediatrician side is work with young teams to develop goals. What do you want to accomplish? What's going to help you become an independent adult? Or what's going to help your family move towards independence as much as possible? So I think that kind of shared plan of care and goal setting is important. I think certainly the American Academy of Pediatrics calls for a specific transition of care plan. And I think the Care Path for Kids could also be used as a tool to develop such a plan.
Great. So we're going to start closing out. And Allie, if you could put up the slide that just reminds people of the website where they can learn more, and we welcome all feedback. And I would like to just ask for any final reflections, specifically from you, Melissa, having listened to families, any quote that you recall or just your gut takeaway on you've heard the dialogue today and what people have asked about. And so I just want to ask you to maybe give us some of your reflections as we close here today.
Well, I think a lot of it, especially the families that I worked with, that most of them came through family voices, state organizations, whatever. They are used to advocating for themselves and used to helping advocate for other families. And, they know that if they need something, they've been trained to realize it's okay to go after it and ask for it. And so, they could be a good group to drive the acceptance of this tool just by taking it, using it, showing it to their own healthcare team and saying, look, this is helping me. This is why it's helping me. It would help me if you would also engage it as well. I think it just opens up so many important conversations that you don't ordinarily expect to have with your doctor in a 15-minute time period or whatever. It allows you to really focus in on the important things and let your healthcare team know that these are the important things too. So
thank you, Melissa. And in that way, it's more of a cultural change. Even just completing it sends a signal of a cultural change that we know we all want, that's built into all of our health reform plans. So I want to thank our panelists, and I wish we could keep going, but thank you, Jonathan, thank you, Melissa, and thank you, Dr. Bergman. And also thank you to the Lucille Packard Foundation for Children's Health. And here is a final slide to help you learn more about their work on children and youth with special healthcare needs, which is extensive, and we are deeply grateful for their ongoing leadership all these years. Thank you, everyone.